Thank you very much. It's a great pleasure. Thank you to Respicon for inviting me to this meeting once again. And I'm
Excuse me?
Yes?
I would like to introduce
sorry.
you because it's my privilege and honor to introduce such a personality in pediatrics. And I know that their CV is there, but I also collected some from here, and I want to say that it's my pleasure to introduce such a pediatrician of such vast experience, knowledge, research experience, and social upliftment activities of children. And he is now a professor, University of Southampton, and a visiting professor, University of Latvia and Singapore. And he is the regional director of pediatric cystic fibrosis services across Wessex. And he is the educational lead for Southampton Hospital and head of the School for HEE, creating the UK first school of pediatrics and child health. And he has been a member of Wessex Senate 2014-18 and the Commonwealth Scholarship Assessor. And he is involved in numerous charitable activities, including the Child Health International Initiative, which supports the cystic fibrosis treatment in developing countries. He has an ongoing research portfolio focusing on nutrition, respiratory health, and development of novel therapies to treat cystic fibrosis lung infection. He has a particular interest in the psychosociological determinants of asthma in westernized societies, and many publications on cystic fibrosis and pediatric respiratory medicine, and the author of a textbook on management of cystic fibrosis. So that is my
One addition from today's lecture of Dr. Gautam Cush. He in his younger days, he was most like a Hollywood star.
I'm not sure about that. That was a very kind introduction. Thank you very much indeed. So, thanks very much for the invitation to be here once again. And I'm particularly pleased that it's here in Calcutta because my father was born here. And so I've had the privilege of coming to visit his birthplace, which was very special for me indeed. So I've been asked to talk about non-CF bronchiectasis. I'm more of a cystic fibrosis specialist. I'm a late fill-in for this particular subject. So just put that qualification up before I start. So I thought I'd start with a simple description of what bronchiectasis is. It's a relatively straightforward concept, I think, to understand. There's abnormal dilatation of the bronchi. There's a lack of the cilial function on the airway surface, there's increased mucus production, and there's destruction of the bronchial wall, leading to dilatation. It can be persistent, or it can be progressive, and it's quite useful to try to think about it in that way, because I think the implications for treatment might be different according to whether or not it's a progressive disorder. The pathognomonic feature of bronchiectasis is the CT scan appearance, and the current definition is a measurement in relation to the size of the pulmonary artery adjacent to the bronchus. And if the ratio is greater than 0.8 in the internal diameter of those two structures, then you have bronchial dilatation. And that would suggest bronchiectasis as an underlying problem. This pathogenesis concept put forward by Cole in 1980, I think still holds true. I think the starting point on that circle is the mucus plugging. That leads to an increased growth of particular bacterial species, which can be pathogens in the CF airway. There's an immune response to those bacteria leading to inflammation, and that in itself then leads to the destruction of the bronchial wall as a result of the release of cytokines as part of that inflammatory immune response of the host to try to deal with these bacteria that are present in abnormal numbers in the airway. And that leads to a vicious circle of recurring lung damage and worsening bronchial dilatation over time. Here's a list of causes. It'd be interesting to hear from you guys as to what the top causes would be in India compared to the UK. But we see most commonly post-infectious bronchiectasis. We heard a lecture this morning about obliterative bronchiolitis that might also be present, but in many of our cases, we just see bronchiectasis. We see some patients who have delayed presentation with missed foreign body, and that obstruction of the airway by the foreign body can, in a similar sort of way to what we see in cystic fibrosis, lead to bacterial infection and airway damage. Immune deficiency is an important cause. Probably the most common, although it's treatable cause, is X-linked agammaglobulinemia, but other immune deficiencies can also occur. And we also see some patients who have congenital lung abnormalities. And probably the most common one, I would say, is pulmonary hyperplasia as a sequelae to diaphragmatic hernias. But other congenital lesions can also lead to lung damage, particularly when the airways are abnormally narrowed. Chronic aspiration can cause bronchiectasis. I think it's fair to say that's more of a problem in those patients who've got neurodisability. I think it would be very rare to see this occurring in an otherwise normal child. And certainly in my country, such children are identified quite early on, and they're usually enterally fed with vaginal-type tubes to prevent that reflux-type complications from occurring. We're not going to talk about cystic fibrosis. Anthony is going to talk to us about PCD shortly. We heard about ABPA this morning. I think we see that certainly in cystic fibrosis as a complication causing worsening bronchiectasis. Extremely rare in my country to see that as a complication of asthma, but I gather you see that more commonly here, as we heard this morning. And then finally, connective tissue diseases, and we see a number of patients with inflammatory bowel disease who have associated lung problems, and the most common one that we do see is also bronchiectasis. I thought I'd just mention very briefly Anne Chang's work looking at protracted bacterial bronchitis. And she has a hypothesis that this is the seedbed for the progression to what we call chronic suppurative lung disease, which might then result in bronchiectasis, as we see on CT scans. And there may be a progression of disease here for which there's an opportunity to intervene and prevent the progression from occurring. It's very much a hypothesis, and there's no good evidence to prove this progression, but it's worth noting that the bacteria that occur in PBB and bronchiectasis are very similar, and here are the usual suspects: Strep pneumoniae, Haemophilus, Moraxella, and in a small number of patients, Pseudomonas aeruginosa. Adenovirus type C is also seen when it's looked for, and that's thought to be a particular risk factor for this complication. The pathogenesis as to why this might occur, I think, in PBB is not really very clear-cut, but there's a few things which are thought about. One is the presence of tracheobronchomalacia, very much something that's in the eye of the beholder, of the bronchoscopist, person looking down the airways, who might see this complication as a risk factor for the infection that can then occur distal to that abnormal airway. And increasingly, we're looking at inflammatory mediators, which are the cause of lung damage, and the recognition that there are different types of expression of various kinds of cytokines, metalloproteases, which might be upregulated in some individuals for genetic reasons, and that's why they're more prone to having the complications of lung infection that can progress to bronchiectatic lung damage over time. I am quite interested in this condition. This is a chest X-ray, and it shows you'll see some obscuration of the right heart border, perhaps some increased perihilar thickening, and this is so-called middle lobe syndrome. And it's quite curious, this doesn't really feature very much in the bronchiectasis literature, but I think it might be more relevant than we think, and it might also explain PBB, I think. And typically what you see with middle lobe syndrome is collapse, volume loss in the middle lobe. Often the lingula is also included, and that can lead to recurrent infection, which over time can result in bronchiectasis. And I like this concept because I think it can be explained as a pathology in a better way than PBB. It's known that the middle lobe and the lingula have poor collateral ventilation, so they're prone to atelectasis. Their bronchi are smaller on average than other major bronchi, so they're more prone to being blocked by mucus secretions. If you inhale something the wrong way down into your airway, the line of least resistance, the straight line down in an upright person, is into the middle lobe. And if you have hilar adenopathy, that can quite easily distort the origins of the lingula and the middle lobe, and that can lead to problems as well. So I think this might be an important risk factor as well. Eosinophilic bronchiectasis, I'm not sure if that exists or not, but certainly asthma and eosinophilic inflammation you can imagine, be a risk factor with bronchoconstriction to infection, which could lead to bronchial damage and bronchiectasis. There's some data here taken from adults. These are patients who have chronic Pseudomonas infection with bronchiectasis, and those with high eosinophil counts are more likely to progress to have a poorer survival than those who don't. So there may be something in there. We don't know about pediatrics, but it's worth thinking about. Finally, we have idiopathic bronchiectasis, and up to 40% of adults have this label. Quite tantalizingly, it's seen in families. It can be familial. That throws up the prospect of as yet unrecognized genetic causes, perhaps. And also, we're still speculating as to why this might be happening in some patients. And my colleagues talk about the possibility of there being abnormalities of mucus, of the airway secretions, that we've not yet characterized, that might be a reason why mucus obstruction leads to infection, leads to bronchiectasis. So there's a lot more to learn here, and a lot more research that may yet give us some interesting insights into why this occurs. The classic symptom is a chronic, moist, productive cough. Most patients with asthma respond to asthma treatment. If you have a failure of response, particularly with cough as an ongoing symptom, then think about other pathologies, comorbidities such as bronchiectasis in those patients. Sputum cultures in patients producing purulent sample is highly suggestive. Recurrent pneumonias, severe pneumonia without recovery, with ongoing chronic cough beyond 6 weeks, persistent chest X-ray changes, unexplained hemoptysis, quite rare in my country, and then the clinical features of things like PCD, the patient with deafness, the child with failure to thrive who might have cystic fibrosis. Clubbing, as you all know, is a feature of bronchiectasis, so do look at those nail beds, look at them sideways on, and look for that pathognomic feature of lung damage. And the chest X-ray is usually abnormal. Not always abnormal. You can be caught out by a normal chest X-ray, but typically you do see changes, and the characteristic changes you see are the tram lines or abnormal cystic changes on the chest X-ray film. And there's two categories, three, but two common categories of bronchiectasis that are talked about on the CT scan findings. The cylindrical type of dilatation and a more cystic type, which I think is a progression to a more severe disease state. Here's some examples of the chest X-rays. You can see there, I think, in the right mid and lower zone, that tram lining, the actual definition of the thickened bronchial walls, which are abnormally dilated. And here you can see the more severe cystic changes of more progressive lung damage with more advanced bronchiectasis. So here's some CT scans showing those in more detail. And as I already said to you, the CT scan is the gold standard diagnostic test here. A little bit of a hint of cause as to the site of the bronchiectasis: upper lobes, cystic fibrosis, aspiration, and I think tuberculosis might be more likely. Middle and lower lobes, think about PCD and aspiration. What blood tests and investigations do we do? Well, a full blood count to look for neutropenia, look for a raised eosinophil count, look for evidence of inflammation, exclude immunodeficiency, think about ABPA, further immune tests if you are suspicious about infection elsewhere to suggest a problem with the immune function, think about cystic fibrosis, and think about PCD. Further investigations, a barium swallow or pH study for the child you think might be having aspiration risk, particularly if there's neurodisability. The role of bronchoscopy, I think, quite important for culture purposes, to exclude foreign body and to exclude airway congenital abnormalities. And then we also have the tests for autoimmune profiles to think about connective tissue and rheumatological type diseases. The aims of treatment are to try to identify the underlying cause. If there is an underlying cause, it's very important to think about the aspirations to prevent disease progression. You want to maintain lung function, you want to impact upon reducing risks of exacerbations, and of course, with our growing, developing children, you want to make those things as normal as possible for them, despite their disease. Some general measures. Patient education is very important. People need to understand the nature of the problem they have. They need to know how to get help, to recognize early the need for antibiotics to treat respiratory exacerbations, to prevent further lung damage. They need annual vaccination. We heard about flu vaccines, very important for this population. And clearly they must avoid smoking. We do regular surveillance, regular microbiological testing to look for bacteria. We don't treat those routinely, but we have an idea of the prevailing microbes to give antibiotics for at the onset of any increase in symptoms. We give treatment for 14 days, first-line oral to cover those bacteria, and we eradicate Pseudomonas if we find it. Pseudomonas, again, is associated with worsening outcome. Here's some adult data showing that exacerbations are more frequent with patients with bronchiectasis. So if we find this bug, we should try to remove it from the airways. Azithromycin is worth mentioning. There is data suggesting that this antibiotic, I don't think it is an antibiotic, I think it's an immune modifier. It changes the host immune response to bacteria in the airways. It downregulates inflammation, and its use is associated with better lung function and a decreased time to respiratory exacerbations. So patients who have exacerbations certainly would benefit from regular azithromycin prophylaxis. IV antibiotics are used for those patients with more severe symptoms. Physiotherapy we're going to talk about later on in this session, so I won't mention that now at all. But I just thought I'd finally mention one other drug that's on the horizons, not yet in pediatrics, but there's been a phase 2 clinical trial of brensocatib in bronchiectasis in adults. And this, quite interestingly, is an anti-protease drug. So it's downregulating, again, the host immune response to the abnormal proliferation of bacteria in the airways. And there's now quite good evidence that this drug can be effective in reducing exacerbations by a significant degree. It downregulates inflammatory markers in the airways. You can see here a reduction in elastases in those patients taking the drug compared to placebo. And again, it reduces the number of patients going on to have exacerbations. So that's the end of my talk. A few take-home messages. Think about the diagnosis if symptoms are suggestive. Think hard about the reason why the bronchiectasis is present. Try to decide if it's a progressive or non-progressive disease because it has implications for treatment. And follow patients up. Think about physiotherapy and think about nutrition as well. Thank you very much. I'll stop there and take some questions.
Wonderful lecture, sir. A few questions may be asked. One question to sir from myself. In case of Pseudomonas, that is inhibiting the bronchiectasis spaces, inhaled tobramycin probably the drug of choice.
Yeah.
Any other drug for this?
No, I think there's, we've learned about Pseudomonas mostly from cystic fibrosis and the concept of eradication in that disease. I think it's applicable to other causes of bronchiectasis, including, I'm sure, PCD. I think there's equipoise in terms of the relative benefits of what you do, but I think the important thing is to treat it. I think a month of nebulized tobramycin is as good as giving nebulized colamycin, which we have in the UK. And I think it's as good in the well patient as giving intravenous antibiotics. We've had research in the UK showing equivalent outcomes for eradication comparing intravenous and nebulized therapies. So I don't think it matters too much what you do, but don't ignore it. Do treat it and follow up microbiology.
So 2 questions. Untreated long-term asthma can cause bronchiectasis, number 1. Untreated asthma can lead to bronchiectasis later on if untreated for longer time. Asthma.
Yeah, it's a really good question. Does asthma lead to bronchiectasis? And if you look at difficult asthma patients in adult clinics who have high-resolution CT scans, some of them do have bronchiectasis. So it does raise this question about the association and whether eosinophilic bronchiectasis is a thing or not. I suspect that asthma, by its nature, causes smooth muscle contraction, it narrows airways, and may predispose to obstruction with bronchial casts, as we see in patients who end up in our intensive care units. And I can see how that process can then lead to infection and lung damage. I think it's relatively rare in pediatrics. We should be controlling asthma with good prevention therapy with inhaled corticosteroids, but I think the undertreated patient is quite possibly at risk of this complication.
So that time we have to treat both bronchiectasis as well as asthma, right? So we have to add on also this therapy for bronchiectasis.
Yeah, I think you should think about it, certainly. And I guess the question is, if you're controlling the disease with prevention therapy for asthma, you don't have to worry about it. If you're not, and you have ongoing symptoms, I think I see what I call middle lobe syndrome I touched on in some of my asthma patients, and I find that, viral infection causes asthma exacerbations, but chronic poorly controlled asthma can be due to bacterial infection, and antibiotics may have a place there. But it's a small number of patients.
Okay, sir. And what will be the lung function in bronchiectasis?
Yeah.
FEV1, FVC?
Good question. I didn't touch on it, did I? But I think certainly for our patients in the UK, most of them have relatively normal lung function. Lung function can decline with severe progressive disease, and you want to try to optimize lung function as much as possible. But I think it's the lung function doesn't really give you a diagnosis. It's only an indicator of severity and only goes down when there's quite significant lung damage. Much the same as cystic fibrosis, in fact. We see quite significant bronchiectasis in CF patients, and their FEV1s can still be 100%.
Thank you, sir.
So we conclude this session. Okay.
Thank you, Professor Cornett, for your wonderful lecture. Thank you.
Thank you. And thank you to the chairpersons as well.